Hi, my name is Allison Bruff, and I'm here to talk to you about improving smoking cessation through lung cancer screening. Now, to start off from the top, talk to you about smoking. The top four major causes of mortality in the United States are actually related to smoking. These are cancer, cardiovascular disease, stroke, and respiratory illness. And smoking actually accounts for 90% of COPD-related deaths. Now, the prevalence is higher in developing countries than in the U.S., and this is because of the strong health policy campaigns that have actually promoted smoking cessation in public and at work. So because of this, in the U.S. from 1965 to 2010, the prevalence of cigarette smoking among adults has actually decreased significantly from 42.4% to 17.8%. And smoking cessation, when you actually ask current smokers, around 70% of them want to quit, and 44% of them have admitted to an attempt to stop within the last year. But because they have no help or no treatment program, only 4 to 7% had a quit rate still at 6 months. Now, counseling includes anything from assessing smoking status, determining readiness to quit, use of a decision tool, and then ultimately developing a plan. Now, aids include anything from medications such as bupropion, which is known as Wellbutrin, varenicline, which is known as Chantix, or nicotine replacement therapy in the form of a patch or gum. Otherwise, you can offer group or individual counseling or provide self-help materials as well. Now, lung cancer is an aggressive and it's a lethal disease. It's actually the leading cause of death from cancer in both men and women in the United States, and it has a very strong association with smoking. According to the American Cancer Society, 14% of all newly diagnosed cancers are actually lung cancer. And they estimate in 2017 that there will be over 220,000 new cases of lung cancer, with over 150,000 of deaths related from lung cancer just in 2017 alone. The highest incidence is actually in blacks, and they found that also that blacks and Hispanics have a lower survival rate than Caucasians. Whether this is due to medical mistrust that has been found in minority communities, which then leads to further progression of their disease at diagnosis. There are many factors to why that is the case. Now, the high-risk population for lung cancer includes current smokers who have at least 30 pack year history. Now, to calculate pack year, you take how many packs a day a person smokes, and you multiply that by years smoked. So, for example, a person who smokes 2 packs a day and has smoked for 15 years has a 30-pack year history. Also, high-risk people are former smokers who quit within the past 15 years, and it includes people from ages 55 to 80. Now, the public health response has been fairly robust. In August of 2011, after a large study funded by the National Institute of Health was conducted that showed just receiving a low-dose CT scan could reduce mortality from lung cancer by 20%. Various policies and guidelines were also implemented because of this. So in December of 2013, the United States Preventative Task Force recommended that annual low-dose CT scan screenings for adults should happen with people who are at risk. And in February of 2015, the Centers for Medicare and Medicaid committed to insurance coverage for people who are at risk to get annual low-dose CT scans. And in order to be fully reimbursed, these people also had to undergo smoking cessation counseling and have a shared decision-making visit. Now, to explain what lung cancer screening is, like I mentioned before, most patients who are undergoing lung cancer screening, they're actually interested in quitting. But barriers to actually getting this lung cancer screening are wide. These include lung cancer stigma, whether it is feeling self-blame or feeling like the cancer diagnosis inflicted, and this is usually because of people thinking that by smoking they brought it on themselves. They might feel they might be judged because other people will look at them and say it's your fault. Also, people who are currently smoking think they don't benefit from screening. Another barrier is the actual physical addiction to nicotine. There's mistrust of the healthcare system. If you think everyone is out to get money from you, you're not going to want to get screened. And the fatalistic belief, the idea that, oh, well, I'm diagnosed with cancer, I'm going to die, it doesn't make sense to continue screening. Now, to examine how lung cancer screening can be used to help with smoking cessation, I looked at a couple of theories. The first theory of note is the trans-theoretical model, or the stages of change. Now, many studies have actually used the trans-theoretical model, especially when pertaining to addiction behaviors such as drug use, alcohol use, and smoking use as well. Now, this theory is founded on the idea that behavior change is gradual and that people progress through stages using different change processes. And these constructs include stages of change, processes of change, decisional balance, and self-efficacy. Now, just to remind you guys of the stages of change, they're pre-contemplation, contemplation, preparation, action, and maintenance. Now, the pre-contemplation stage is one where the person has no intention of changing their behavior within the next 6 months. And this can be just because they have no idea that their behavior is bad. They just have no knowledge about it. Or it could even range to just lack of motivation. For example, what if they've tried to quit in the past and it was unsuccessful? Now they have no desire to try that again. The contemplation stage involves the intention to take up the behavior in the next 6 months. Preparation stage is when they intend to adopt that behavior in the next 30 days. They're planning for it. The action stage is that they've changed their behavior of interest, but it's been less than 6 months. And then the maintenance stage is that they have greater than 6 months of behavior change. Now, one study that used the trans-theoretical model actually was a study out of Iran that looked at a group of daily smokers, and they assessed their state of change, and they actually only chose to look at people who were in the preparation phase. They divided both groups up into, they divided the group up into two groups, the control group and the intervention group. Now, both groups received an introductory session, and they received some materials as to that would describe the study. However, the intervention group received significantly more resources in the form of multiple counseling sessions, over 45 minutes each. They also received nicotine replacement therapy dependent on their nicotine dependence, and they had multiple follow-up phone calls to assess for continued progress. Now, the study found that 40% of the intervention group was able to reach maintenance, whereas none of the people in the control group reached maintenance stage, and only 3 of them reached the action stage. And essentially, these authors concluded that a smoking cessation program would be more effective by focusing on highly motivated people, i.e. people in the preparation stage only, and delivering to them individual counseling and then subsidizing the cost of nicotine replacement therapy. A second study that looked at the trans-theoretical model was actually integrated both the TTM and message framing, and they wanted to see whether intention to quit smoking was influenced by gain or loss framing, and whether or not this had to do with their state of change as well. And so in this study, they hypothesized that people who were in the pre-contemplative stage would not be affected by the TTM at all. However, they were able to find that gain-framed messages or messages framed about the benefits of quitting were more effective in the earlier stages, such as pre-contemplation and contemplation. And then they found that people in the later stage, such as preparation, were more attuned to listening to a loss frame message. The second theory that I looked at is the theory of planned behavior, and this represents an individual person's intent to perform behavior, and this focuses on the constructs of attitudes, subjective norms, and perceived behavioral control. And one study describing smoking cessation and the theory of planned behavior happened in Norway, where they once again also surveyed daily smokers, and they surveyed them at two consecutive times, and they actually were able to conclude that these smokers had the smokers that had high perceived behavioral control as well as positive attitudes towards quitting, they had a higher intention to quit. And in addition, they found that attitudes were more predictive of intention to quit when these people were in a supportive environment as well. So some critiques of the trans-theoretical model is that a strength is that smoking cessation techniques can be matched to a patient's stage of change and tailored to have the best chance of success. It can also be used with motivational interviewing to increase efficacy. And the weaknesses, a meta-analysis found that actually stage-based interventions were neither more nor less effective than their non-stage-based equivalents. And some studies assume a forward progression only through the stages and do not take into account relapse or regression. For the theory of planned behavior, strengths include successfully being able to predict intention to quit smoking and explain beliefs behind a behavior, but weaknesses include not actually being able to predict actual smoking cessation. And so the next steps include creating a successful smoking cessation program that is integrated into the lung cancer screening program. Now, we need to target the shared decision-making aspect of the screening visit. We need to assess smoking status and the attitudes and beliefs about smoking and patients' readiness and willingness to quit. We need to discuss radiologic findings and their meaning, whether they're good findings or bad findings. And then we need to teach about smoking cessation aids and develop a plan for quitting. To this end, we have this theoretical model which takes into account the age, education, socioeconomic status, smoking history, comorbidities, and other exposures, and applies that to the lung cancer screening patient. And in this visit, we take the radiologic findings, whether they're negative or benign, positive or concerning, and use that as a way to discuss the individual patient's smoking effects on their long-term health. This can also be used as a teachable moment to go through stages of change, once again determining a patient's intention to quit. All these are related to attitudes which have been found to have influence to intention to quit, as shown by the theory of planned behavior. By looking at attitudes, intention to quit, and their perceived control, we hopefully are able to increase smoking cessation with lung cancer screening. Thank you for listening to my presentation, and I look forward to your comments.